next talk this morning will be given by Dr. Candice Silversides, and it gives me great pleasure to invite her. She was always welcoming, taught me quite a lot during my cardiology training in Toronto, always willing to teach and always willing to have me present. So that helps with me being back at home, offering cardiology services. So I publicly want to thank her for that. And she is the professor of medicine at the University of Toronto, director of University of Toronto Cardio Obstetric Program, and editor-in-chief in the Journal of American College of Cardiology. For me, once, while I was doing my training, once you said pregnant women or pregnant woman and heart disease, Dr. Candice Silversides definitely would have been involved in the care of that patient. She has had 200 publications and has authored chapters in leading cardiology reference texts, including brown wall heart disease. She has helped with multiple international practice guidelines and chaired the Canadian Cardiovascular Society guidelines on adult congenital heart disease in 2010 and 2021. And she was absolutely and definitely quite rewarding, was awarded the Kent Ulan Distinguished Career Award for her role in advancing the field of cardio obstetrics. So thank you so much, Dr. Silversides, for accepting our invitation. And we do look forward to your talk this morning. Dr. Silversides.
Okay, thank you very much. And well, first, I just want to say thank you so much for inviting me to be here. I'm so excited and I'm so honored. And I am speaking to you from Toronto in Canada, where the weather is, I'm sure, not as nice as where you are right now. But again, thank you so much. So today I'm going to talk about peripartum cardiomyopathy. So a little bit different than the last talk that really covered a lot of different conditions. I'm going to hone in to details about one condition. What's interesting about peripartum cardiomyopathy is that a lot of what we originally learned about peripartum cardiomyopathy came from the Caribbean. So I think maybe this is a perfect talk for this meeting. Unfortunately, I probably won't present as much of the original Caribbean data because that is really become now supplanted by more contemporary data. But I really would say the Caribbean and research done in the Caribbean led the way to the understanding of this condition that we know today. So to begin, I want to tell you I have three objectives. First, I want to tell you a little bit about why peripartum cardiomyopathy occurs and how women present, then talk about the prognosis. And finally, and probably most importantly, I want to make sure you understand where the current guidelines are in 2022 with recommendations about how to tackle peripartum cardiomyopathy. And I wanted to do all of this anchored on a case. So to start the case, this is a woman that was seen in Toronto. She's a 40-year-old who presented at 36 weeks gestation. She was African-American. She had no previous medical history. She did have a sister with heart problems when she was pregnant, who was subsequently told never to get pregnant again. And she had gestational diabetes during this index pregnancy. So she came in short of breath. Her blood pressure was stable, so she wasn't in shock, but she was tachycardic. Her renal function was fine, but her echo showed moderate to severe LV dysfunction. So unfortunately, I can't do polls, but I want you in your mind to commit to an answer, and then we're going to work through some of these answers over the course of the talk. So would you tell this woman she had peripartum cardiomyopathy? So I said the answer is maybe, and that's because peripartum cardiomyopathy is a diagnosis of exclusion. So I'm going to keep re-referencing this review article that came out in JACC in 2020 as I walk through it, because it's an excellent review article if you ever see someone and you're worried about peripartum cardiomyopathy. And I also think it's just a good way to walk through this condition. So the definition, very loosely, is it's a non-ischemic cardiomyopathy with an EF less than 45% that typically presents right after women deliver in the first, 2 to 4 weeks, or right at the tail end of pregnancy, similar to some of those conditions you heard about with stroke in pregnancy. It is a differential of a diagnosis of exclusion, so you have to make sure there's no other causes. In 2022, I think one of the most important causes to exclude would be myocarditis due to COVID. But you do have to make sure it's not a pre-existing cardiomyopathy, ventricular dysfunction for any other causes. And if you can't find any, you start working with this idea that it might be related to the pregnancy and a peripartum cardiomyopathy. Now, as I mentioned, a lot of what we know about peripartum came from work in the Caribbean, and that is because certain parts of the Caribbean, like Haiti, have a very high prevalence. And so worldwide, there is a lot of difference there's a lot of discrepancies in the prevalence of peripartum cardiomyopathy. In Nigeria, the prevalence is about 1 in 100 pregnancies. In North America, so in Toronto, where I'm from, it's probably around 1 in 2,000 or 1 in 3,000. In Japan, it's very, very uncommon at 1 in 200,000. So there is a lot of discrepancies worldwide. I tried to find out if there is any data locally, and I couldn't find it for you, but perhaps somebody in the crowd knows and can mention it at the end. In addition to this idea that there's discrepancies worldwide and perhaps in some parts of the Caribbean, in fact, very high. So in Haiti, the numbers, 1 in 200, 1 in 300. There also is other risk factors. So African-American race is an important risk factor. I'll talk about that a little later. Women that have preeclampsia or hypertensive disorders in pregnancy it is highly associated with peripartum cardiomyopathy, and I'll come to that later as well. And then older age. And there's different ways women can present, and I'm going to talk about that in a lot more detail. But there are cohorts of women that are at higher risk. So perhaps when you get a woman with a bad EF and that's pregnant or just completed a pregnancy, think of those risk factors as well. There's lots of reasons that people have proposed that peripartum cardiomyopathy develops, whether it's inflammation or infection or an autoimmune response. There's all these ideas that have come through over time. Kind of where we've landed is the bottom two explanations on this chart from a number of years ago, which are related perhaps to prolactin or other vasotoxic hormones or genetics. So I just want to tell you a little bit about those etiologies, because currently that's kind of where people are thinking we should be thinking about the pathobiology and targeting treatment. So this idea of vasotoxic hormones is that they're released either from the placenta or the pituitary gland in the case of peripartum cardiomyopathy, and that occurs early postpartum. It damages the cardiovascular microvasculature. You get cardiomyocyte damage, and then you get contractile dysfunction and the bad EF that we see clinically. At least one important cardiotoxic hormone that's been implicated is prolactin, because when prolactin is cleaved, that cleaved molecule is highly vasotoxic. And there's knockout model mice that have shown that prolactin, that cleaved product, affects the mice myocardium. And the other support of that is when we see prolactin peak. So this graph on the x-axis here shows the weeks gestation and the weeks postpartum. The bars show you when women present with peripartum cardiomyopathy. You can see most of it happens in the first month postpartum. And if you look at the prolactin and also another potentially implicated vasotoxic molecule called S-FLT, which comes from the placenta, you can see that those two molecules, that red peak, happens right before the clinical syndrome of peripartum cardiomyopathy. And so it kind of fits that they may be part of the pathogenesis. So just to show you this in a little bit of a different figure, you have vasotoxic molecules coming from the brain in women. That's prolactin. It gets cleaved and it's a vasotoxic molecule that causes endothelial dysfunction and cardiomyocyte damage. Down in the placenta, you release S-FLT. That inhibits the VEGF pathway and triggers peripartum cardiomyopathy. And as I said, there's been animal models to support these. But it's probably not the whole story. Everything doesn't fit, although these are clues. However, this is a study that looked at 170 women with peripartum cardiomyopathy who had gene sequencing, and 15% of them had high impact variants. So variants in genes associated with cardiomyopathies, and the majority of those were in the Titin gene, the TTN gene. But still, what it shows you is what we call peripartum cardiomyopathy and who it develops in and how it develops. I think we still don't have a complete understanding. And perhaps one day these genetic variants will simply be a subset of their own. But there is a lot of different potential mechanisms. Currently, though, this vasotoxic idea is prevalent. So how do these women present? Well, They can come in completely asymptomatic, who, get an echo for a different reason and you find they've got a bad EF. They can come in with pulmonary edema, either in really bad shape or just subtle pulmonary edema. Some will come in cardiogenic shock. Some will have a cardiac arrest because the association with ventricular tachycardia. You can get LV thrombus when you have this low flow state, plus pregnancy is a prothrombotic state. So you kind of have a double hit of bad flow in the ventricle and a prothrombotic state. So some will have thrombus, and then some, women will present with sudden death. I do want to mention thrombus because it's going to come up again later when we talk about management. But LV thrombus is reported anywhere between 10 to almost 20% of pregnancies in women with peripartum cardiomyopathy. So, you've kind of seen this before, but I just want to highlight it again. This shows when women with peripartum cardiomyopathy present to hospital. On the x-axis, you can see the weeks prior to delivery, starting at 28 weeks gestation, and you can see the weeks after delivery. On the y-axis, you see the number of patients in this series by Dr. El-Kayam back in JAC, where he reviewed the literature. And what you can see is when you look at when women present, most will present in that first month postpartum. And often it's in the first week postpartum. These women present, perhaps they had some subtle signs early at the tail end of pregnancy, then they deliver, they get fluids at the time of delivery, maybe the disease just progresses and they come in early after that with pulmonary edema. Often what happens is they come in, somebody doesn't even think it's peripartum. They think it's more likely a PE or something that's actually more common in pregnant women. They do a CT scan, find pulmonary edema, and then you're starting to work up peripartum cardiomyopathy. But this is the timing of when these women walk in. This is a document from the European Heart Failure Society where they break up the presentation of what to look for and then categorize women into mild peripartum, moderate peripartum, or severe peripartum disease. And so mild is just women who have kind of subtle subacute heart failure. Acute is when they're in more frank heart failure, and severe peripartum is where they present in cardiogenic shock. The ECG shows nothing specific often. The chest x-ray obviously shows pulmonary edema. The BNP is elevated, but increasingly elevated depending on the condition of the woman. And echo shows worsening LV dysfunction, often related to the severity of peripartum presentation. So that is why peripartum occurs and how women present. And now I want to talk a little bit about what the prognosis is for these women. So, the worst outcome potentially is mortality or heart failure. This is a review, again, I've mentioned it earlier, but it's a review that was done by Yuri El-Kayam in 2011. And he looked at all the literature on peripartum cardiomyopathy coming from the United States. So again, it's specific to the United States, but it looks at all the series that were reported. In the first column is the authors, and the second column shows you the number of women and the follow-up periods. What you can see is follow-up varies in terms of months postpartum or months to years. Sometimes it's not even reported, but it is, these series reported anywhere between 19 months and 8 years postpartum. And you can also see the number of women reported in each of these series individually is not too high, apart from the Golan series at 182, but it is a relatively rare condition. So keeping in mind, there's a lot of variability in between studies. What you can see is mortality is also very different, ranging anywhere between 0 and 18%, depending on which study is reported. Now, not only is there a lot of variability with the methodology, but I would also mention there's also differences. These are retrospective studies. There's lots of inherent limitations because of the retrospective nature of the studies. And so perhaps that may explain at least some of the differences, but these are really striking differences. If you look at the need for heart transplant, again, it varies similarly anywhere between 0 and 11%. So, there was a lot of differences in the reports in the literature, and where what I just, before I go on to that in a bit more detail, I just need to mention that most of the maternal mortality is due to refractory heart failure or sudden death. So that's what they're looking like before they die. But as I said, there is a lot of variability in how often these adverse outcomes occur. And so as a consequence, Dennis McNamara, who I've got a picture of here, and actually Jim Flett, who's the picture, the larger picture up in the right-hand corner was in his clinic in Haiti. They got together and did a prospective study, very rigorous, looking at what were the outcomes in North America. And so they collected prospective outcomes on 100 women from around North America. There were 4 deaths in that prospective series. So I think this is probably a reasonable estimate in North America, what the mortality is, because it was such a well done prospective study. If you actually combined death and the need for transplant, 6 women in the cohort had that adverse outcome, and 6 women had severe chronic cardiomyopathy in follow-up. So these women were followed for a year. So when do women die? Again, back to the review article by Yuri Elkayem. He looked at when they die relative to their index presentation date. So days are on the x-axis, and the percent of women who die is on the y-axis. And what you can see, many die within the first week, the 0 to 7 days. But you can see they continue to have mortality up to 6 months. By 6 months, most of them have died if they're going to die, but a small fraction, just over 10%, will die within the first year after presentation. And as I mentioned, most of the deaths are due to refractory heart failure and sudden deaths. Now, not everyone dies. In fact, the majority don't die. So the other feature about peripartum cardiomyopathy is that some women do okay, and there is a significant portion of women that will have improvement in their LV systolic function. So this just looks at all comers. It looks at their EF at diagnosis. So on the x-axis, you'll see time since pregnancy, since diagnosis. So diagnosis, you can see their EF is 30%. At 6 months is when most of the recovery has happened. By then it's at 45% overall. Remember, some will do better, some will do worse. And by 12 months, you will mostly have full recovery in everybody that is going to recover. So the first 6 to 12 months really define how women will do. So the question, who will recover? And this slide is a really important slide showing who recovers. So if you look at the x-axis, again, this is from that North American IPAC study by Dennis McNamara, and he breaks it into 2 big categories. Women that, when they present, have an EF less than 30%. That's the first 3 bars on the x-axis, and women who come in with an EF greater than 30%. And then he breaks outcomes down into those women who either die or have persistent significant LV dysfunction in the first, in follow-up. So those are the red bars. Then the light blue bars represent women who have some degree of LV dysfunction, but they live and there's some improvement where their EF is between 35 and 49%. And then finally, the purple bars represent women who have full recovery. So what you see is if you walk in the door with an EF of less than 30%, about roughly a third will die or really have a bad outcome. A third will start to get better, but never fully recover. And a third will fully recover. Now, this is quite different than the women that walk in the door at their index pregnancy with an EF greater than 30%, where what you can see is almost everybody falls into that purple bar, which means they have full recovery. So almost 90% will have full recovery. So again, how they walk in their door with their EF is really important in terms of at least getting a sense of how they will do. So when they teased it out a little further, they also looked at the size of the left ventricle. So when they looked at women who had an EF less than 30 and also had an end diastolic volume greater than 6, really none of those women had recovery at the first year postpartum. However, alternatively, for those women that had an EF greater than 30% and an LV less than 6 centimeters, the end diastolic dimension less than 6 centimeters, those women, 90% of them had full recovery by 1 year. So I do think you can start teasing out who might recover early on, at least based on the IPAC series. Now, there is differences globally, and we'll talk about those in a moment. There also, though, is important differences by race. So this is data from the IPAC study looking at peripartum cardiomyopathy outcomes in terms of the improvement in LVEF and LVEF at presentation in non-Black and Black women. So in the IPAC study, Black women represented 30% of the cohort. They actually are, remember I've mentioned African-American race. African-Americans are at much higher risk for developing peripartum cardiomyopathy. And not only that, they're also more inclined to have hypertension, which then is associated with peripartum cardiomyopathy, as I've mentioned. But if you look at the two different categories, you see women, this cohort of women has a lower EF when they walk in the door. And the x-axis just shows time since presentation. So you see the 6-month mark here and the 12-month mark. But what you see is compared to the non-Black population, not only is their EF lower when they walk in the door, but it never really recovers to the same extent. So not only is this group at higher risk for developing the condition, but they also tend not to do as well. There's other variables besides what I've just talked about that are important prognostic factors for peripartum cardiomyopathy. So it's not just about having a bad EF and a dilated LV or being African-American race. There's some data that shows that obesity is associated with worse prognosis. Women that have LV or LV thrombus do more poorly. Women who have concomitant preeclampsia, which is around 20 to 30% of all pregnancies, and again, higher in African Americans. Some data that if your biomarkers are higher, you do worse. And also if you have a delayed diagnosis. So if women don't show up for long after their symptoms develop. And that probably relates to just not getting guideline mediated therapy. So those are the first two parts, talking about the pathobiology and how women present, and a little bit about how we risk stratify and understand the prognosis. And the last part of my talk I wanted to talk about is to review the current guidelines for the management of peripartum cardiomyopathy. So I want to go back to that case. As you recall, it's a woman that probably has peripartum cardiomyopathy, although you could debate. She does have a sister that had a history of what sounds like peripartum cardiomyopathy. So perhaps there's some underlying genetic predisposition, but as you also saw, a significant portion of patients will also have some genetic variant that may be part of the package. She came in with heart failure and moderate to severe LV dysfunction. So which therapies would you consider giving her while she's pregnant? So she was at 36 weeks gestation. Lasix, ACE, beta blockers, bromocriptine. So she was given Lasix. She also got O2. She responded promptly. She got out of her heart failure. And we'll talk about her more, but I want to talk about management with medications during pregnancy. So if we go back to that European Society of Cardiology set of recommendations, where I mentioned they classified peripartum cardiomyopathy into mild, moderate, or severe forms of the disease, they also give recommendations about how to tackle treatment. So for those women, like the woman I just presented, who has kind of mild symptoms, it's mild heart failure, they suggest oral drugs. This woman, we gave IV Lasix, but you could theoretically give oral Lasix if she wasn't too volume loaded. And they suggest considering bromocriptine for a week. A week is a short duration of bromocriptine. I'm going to talk about bromocriptine in a lot more detail because it's probably the most common question I get as a cardiologist is, should we give bromocriptine? So more on that. But they basically, if it's mild, you could give oral Lasix. If it's moderate, those women that have more serious heart failure that might need a heart failure or immediate care unit for monitoring, those women should have IV diuretics if their blood pressure is high, treat it. Now, there is one caveat. They say avoid inotropes or catecholamines if possible. There is some small series out there that suggests that perhaps women with peripartum cardiomyopathy are more inclined to suffer toxic effects from inotropes and catecholamines, so they're less beneficial in the peripartum population. Again, it's not based on really big series, but there's some small series that's suggested. And so it's made it into these guidelines that try not to use them if you can get away without using them. And again, these are the European guidelines, which I would tell you would differ from North American guidelines, but they suggest adding bromocriptine now for 8 weeks, not just 1 week. And then they said, once they're stable, introduce oral heart failure drugs. And finally, for those women that have really severe peripartum cardiomyopathy, so coming in cardiogenic shock, you give IV diuretics. At this point, you use catecholamines and inotropes because you need to keep them alive. The other thing that's important at that stage, so these right-hand bars, is that these women may need mechanical support and or transplant. So, depending on where you're locating at this stage in the game, you might need to think about transferring your patient to a center that has availability of transplant and mechanical support, because these women will potentially need that, and they need to be at a site where you can offer it. So I imagine that would be relevant for some Caribbean islands in terms of mobilizing patients. So the current recommendation is based on the ESC guidelines for the management of pregnancy and heart disease. So this is the first time I'm really mentioning these guidelines, but these were published in 2018. And if you ever see a woman with cardiovascular disease, I would strongly suggest you go to these guidelines. They were written by people around the world with expertise in pregnancy and heart disease. And they're extremely comprehensive, and in my opinion, they're quite practical. So they'll give you some good advice. So I'm going to be re-referencing these guidelines about some fundamental principles of management. But this is the first one I want to highlight, that it is recommended if you have a woman who comes in with heart failure, treat according to guidelines, but respecting the contraindications to some of those drugs that are potentially fetotoxic. So what are those drugs? Well, unfortunately, when women are pregnant, there's a number of them. I'm going to start with the green drugs on this slide, but which should tell you which drugs you can use. So you can use beta blockers. There's a chance of developing a fetal brady and fetal hypoglycemia. But to be honest, as many of you will know, we use beta blockers lots to treat hypertensive disorders in pregnancy. We certainly use it a lot in the cardiac population. And so we monitor fetal growth and we check for, we monitor fetal growth and we check for bradycardias. But the reality is they're not teratogenic and they're used very, very frequently. You can also use Lasix. There's always these caveats. Be careful of Lasix because it might decrease placental perfusion. If a woman is in heart failure, give her Lasix. It is important. If the mom doesn't get better, the baby will get worse, far worse than any worries about placental perfusion. You cannot use ACE inhibitors or ARBs. You can see below, they're in the red category, but you can, if you need to afterload reduce, use hydralazine and nitrates. And digoxin has a long track record in pregnancy. So now to the red categories, you cannot use ACE inhibitors or ARBs because at least during embryogenesis, they can cause congenital abnormalities. The big one being renal abnormalities, but there's a number of other abnormalities that can occur with the use of these medications. Other meds such as spironolactone are contraindicated in pregnancy, and some of the newer drugs we don't have safety for, or we assume they're unsafe based on animal models. So again, for that case I showed you, she got Lasix, she didn't need hydralazine and nitrates right away because she responded promptly. And I'll tell you more about what happened to her. I do want to show you some data about meds in pregnancy. And this is honestly a fantastic study that came from Nigeria not long ago that was published in JACC. And if you remember earlier, I mentioned in Nigeria, the prevalence of peripartum cardiomyopathy is very high. So they were able to assemble a relatively large cohort and they looked at outcome. So they followed these women, 250 women, for an average of 17 months. You can see months follow-up after presentation on the x-axis, and you see mortality on the y-axis. I want to mention two things. First of all, that mortality actually was very high in this series. So unlike that North American series where mortality was 4%, here in Nigeria, mortality was almost 20% here, 18.7%. But what's important is that the women that did better actually had beta blockers introduced after they got out of their heart failure. Obviously, you're not going to start them when they're in florid heart failure, but once they stabilized, beta blockers were introduced. So it's actually, I mean, it's interesting data because it's from a different part of the world that doesn't always publish their data in JAC, but also that they found that beta blockers do seem to be helpful. Now, I want to actually, I've already alluded to these very big differences in mortality between sites. And so these Nigerian authors did provide this table in their paper showing the differences in outcomes in 4 studies. So the Peace Trial, which is the Nigeria cohort I just showed you, the classic peripartum studies came from South Africa, so a South African cohort, the IPAC study from North America, which I showed you, and a German cohort from Europe. And so they just looked at the outcome differences in these 4 different populations. If you look here at LV systolic recovery, so you see there's a lot of variability. In Nigeria, only 25% of women had recovery. That differs than the IPAC study in the States where 70% of women recovered, and in Germany, 90% plus women recovered. You know, there's probably many reasons for that, to be honest. It may even be that peripartum cardiomyopathy in some populations is almost a different disease than what we see in, say, Japan, where it never occurs, or maybe even Canada, where we don't see it that frequently. But certainly at least one variable is this issue of getting guideline-directed heart failure therapy. If you look at the use of beta blockers, you can see that there's a big difference in the utility of beta blockers between these different studies, with it much less commonly being used in that Nigerian cohort where mortality is high, but much more commonly being used in States or Germany where mortality is lower. You also see there's a big difference in using ACE inhibitors after they deliver between sites, and the use of digoxin differs as well. And finally, there's also a big difference in the use of bromocriptine. Not used in Nigeria, but also not used in the IPAC study in the US. However, highly used in Europe, including in this German series. So we're going to come back to bromocriptine in a minute. We're going to come back to it now. So for me to talk about this issue of bromocriptine use, I need to walk through why we might use it. So this is a study in JAC interventions that looked at women with peripartum cardiomyopathy. Now, if you recall, we talked about prolactin cleaved molecule being pathogenic in the disease. Prolactin is released in breastfeeding women. So this study looked at breastfeeding women and non-breastfeeding women who came in with peripartum cardiomyopathy, and it looked at prolactin levels in the serum down here at the bottom part of the diagram. And what you see in the women who are on the left-hand side of your screen, the breastfeeding group, prolactin levels are high. The women that never breastfed had low prolactin levels. Now, there's 2 ways to get those low prolactin levels. One is to stop breastfeeding, which you see in this study, but the other is to use bromocriptine, which stops the production of prolactin. In fact, it was used as a way to stop breastfeeding back in the day. It was ultimately removed from the market because there was some suggestion that it might be associated with thromboembolic complications, which will be relevant as I talk about it. But if you want to decrease your prolactin levels, you can either stop breastfeeding or you can use bromocriptine. And so this idea that bromocriptine might be a way to treat peripartum cardiomyopathy came into being. And this is really the first proof of concept study. It came out of South Africa, where the prevalence is high. It was a study looking at 10 women who received standard of care when they came in with peripartum cardiomyopathy. Those represent the black bars in this graph, and women who received standard of care plus bromocriptine for 8 weeks. Those are the white bars. And they looked at different endpoints. So on the x-axis, you'll see death. You'll see way over here a combined endpoint of death and low EF and NYHA class 3 or 4. And then you see the percent of women who developed it on the y-axis. So if you look at the black bars, those women that just got standard of care, 40% of them died if we look at the first column. And that's in comparison to the women that also got standard of care plus bromocriptine. Now remember, it's only 10 in each arm, but the women that got the bromocriptine, their mortality was only 10%, so a huge difference. And similarly, if you looked at this combined endpoint on the far right-hand side of the screen, 80% of the women who got standard of care did poorly compared to only 10%. However, I just want to point out one important factor. This 10%, So these women who got bromocriptine who had 10% mortality, for instance, that's still much higher than what we see in the IPAC study where almost no women got bromocriptine. So it is very hard to know for sure where we're at. So again, I'm just going back to that IPAC study. You know, the South African study said if you got the bromocriptine, you did way better, but even their way better group was still actually did quite more poorly than this IPAC study where there was only 4 women who died compared to the 10% in the study that I just showed you. And again, just if you look at the up in the right-hand side of this slide, I'm just reminding you that in North America, bromocriptine hasn't gained traction and hasn't hit the guidelines. And so only 1 woman in that series actually received bromocriptine, so quite different than that study. There was also another African study, which actually was a good study that came out of Burkina Faso. And these women were again randomized to standard heart failure therapy here with Lasix and ACEs after they presented and delivered, and then randomized to 4 weeks of bromocriptine. And similar to the South African study, if they looked at EF as their primary endpoint, the women that got bromocriptine had higher EFs. And that's depicted at the graph on your right-hand side that shows time and follow-up on the x-axis, EF on the y-axis. The blue bars represent the women who got bromocriptine. The red line represents women who didn't. And the EF in women who got bromocriptine was much higher over the long term. And in addition, mortality was lower. But again, look at the mortality rates. 17% in women that got bromocriptine, very high, compared to 29% who didn't get bromocriptine, both being very high. But certainly even their bromocriptine arm is much higher than what we typically see in North America. Now, there is one other big study on bromocriptine from Germany, so kind of this other kind of developed country. They looked at the use of bromocriptine, but interestingly, there is no control arm. But they just felt that bromocriptine was standard of care. And so this trial looked at whether or not 1 week of bromocriptine versus 8 weeks of bromocriptine would be optimal. And they followed these women for 1.6 months after they delivered, randomized to one of these 2 short duration or long duration bromocriptine. And they looked at the EF. So their primary endpoint was improvement in EF. You can look at the 1 week bromocriptine change in EF, 21%, the 8 week bromocriptine arm, EF change of 24%, so no major difference, was a negative trial. However, they kind of went on to try and make a point that, hey, maybe the longer one is better. They looked here at, I want to highlight these green bars. This is full recovery, the green bars. The 2 groups are on the x-axis show the 1 week bromocriptine group and the 8 week bromocriptine. Full recovery was present in 52% of the women with only 1 week duration compared to 68% 8 week duration. But as I said, this is a nice study to look at the 2 different arms. And I guess in the bottom line, it's negative. The EF endpoint wasn't different. They tried to turn it a little bit positive, but the reality is I think we still don't know if bromocriptine is the way to go because this didn't have a control arm. They also looked at secondary endpoints just to close off this part of the story. There was no difference in the short or long duration of bromocriptine. But importantly, and I'm going to come back to this again, 3 out of 62 women had a thromboembolic complication. And by the way, all women were treated with some form of anticoagulation because it is recommended because of that risk of increased risk of thromboembolic complications I mentioned earlier, that if you use bromocriptine, you also treat with an anticoagulant. Now, I just want to highlight one more thing. So I'm going to show you the differences in recovery in the German registry and the IPAC registry. And they kind of look the same. If you look at full recovery of EF, it's about the same in the 2 groups. If you look at death or transplant, it's about the same. But going back to the bromocriptine story, in the German registry that I'm showing you here, almost 70% of women got it versus only 1% in IPAC. So again, I'm just highlighting, I don't think we know exactly what to do with bromocriptine. And as a consequence, the guidelines are only giving it a 2B recommendation in those ESC guidelines that I said I would direct you to if you really want advice about how to manage peripartum. They give it a 2B recommendation that you can use it to stop lactation and perhaps enhance recovery. So I think this is why it hasn't been used in North America, but it has gained a lot of traction in Europe where it's used a lot. And there's a lot of papers and a lot of consensus guidelines that come out that say it should be used. They also suggest, as I've kept alluding to, that if you are going to use it, you should use prophylactic anticoagulation. Now, just to tell you, there is an attempt to try and figure out if bromocriptine should be used. There's an NIH study, again, by the lead researcher of IPAC, Dennis McNamara. He's doing a new study called the Rebirth Study. It's coming. The start of it is coming. It will randomize 200 women. The women will get bromocriptine for 2 weeks at 2.5 milligrams twice a day, and then it'll be followed by a lower dose for 6 weeks. So kind of that 8-week regime, and they're going to look at EF, the recovery in EF plus survival over the long term. So I don't have any reports to tell you. I just want to mention that at least in Canada, we haven't routinely been using it, but we really are hoping to that this study will provide some answers. So during pregnancy, just to summarize, again, I'm going back to that review article that I mentioned that I think is excellent. The recommendations are use loop diuretics. They're in the heart failure. You can use beta blockers once they're out. You can use hydralazine nitrates if the EF's really bad, but you have to avoid ACE ARBs. If they're in shock, get them to a center where mechanical support's possible. And if they're in really bad shape, consider early delivery if they're unstable. So the woman I mentioned, she presented at 36 weeks gestation with moderate to severe LV systolic dysfunction. How should she deliver? Vaginal, cesarean delivery. Remember, she got Lasix, topped off, and kind of did okay. Well, we did a vaginal delivery. So let me just tell you a little bit about delivery and the recommendation. The current recommendation is that vaginal delivery, if women are reasonably stable, is the first line. And this is, again, consensus in the ESC guidelines on pregnancy and heart disease. For women who have really severe heart failure, who are in shock on inotropes, cesarean delivery may be reasonable, but the first line approach, for instance, like the woman I showed you who responded to Lasix and stabilized, is to get them in good shape and then deliver vaginally. And that's exactly what happened. So this woman got her meds. We tried to get her in the best possible shape out of the heart failure before she delivers, because the better off they are before they deliver, the more likely they'll do well during the delivery. She was induced a week later, had an art line and epidural and an assisted second stage of delivery and did fine. The reason that everybody says don't just jump to a cesarean delivery, and the obstetricians will tell you this, is that cesarean deliveries have their own complications. It's a major surgery. It comes with more blood loss, increased risk of infection, increased risk of thromboembolic thrombosis, and all those things are potentially bad in women with heart disease. So we tend to advise vaginal deliveries if feasible. For the delivery, just some pointers from that review. It's important that you have a team assembled, not only high-risk obstetricians and cardiologists, but get the nurses on board, everybody on board so they can get these women through the delivery, optimize them before you deliver, and watch how much fluids you give them or they'll pop back into heart failure. So now you remember I said prolactin that you get from breastfeeding or is associated with higher levels if you're breastfeeding, is thought to be implicated in the pathogenesis. So can these women breastfeed? So the answer is unknown. I wanted you to commit, but we really don't know. So, there is this potential therapeutic impact of suppressing prolactin with bromocriptine that has suggested some experts to say nobody should breastfeed. But that's a really major recommendation, especially in parts of the world where breastfeeding is critical to the outcome of the neonate. So in some parts of the world, if you tell women they can't breastfeed, it will have major implications for babies and children. And so it's not a small thing. And we don't really have great data, despite a lot of people having opinions one way or the other. But I'm going to take you back to this study, the diagram I showed you earlier, looking at prolactin levels. In this study, not only did they look at prolactin levels in breastfeeding and non-breastfeeding women, but they looked at how their EF did. This is, again, data from the IPAC study. And if you look at these two groups, the blue bars represent non-breastfeeding women, the green bars represent women who breastfed, and you look at the EF, which is on the y-axis at entry at 6 months and at 12 months, you can see there's really no difference in LV recovery between the women who breastfed and the women who didn't breastfeed. So again, I'm not sure we have good data to recommend that you shouldn't breastfeed. There's lots of good reasons why you should breastfeed. And although some experts say you shouldn't, I don't think we have enough support to suggest that. I think, there is reasons why you might not want to breastfeed, which is it allows you to introduce more medications that might be harmful with breastfeeding. So sometimes you stop breastfeeding because you can ramp up all the heart failure meds. But I think it needs to be decided on a case-by-case basis. So it's actually a 2B recommendation in the ESC guidelines to recommend prevent lactation. So they are not really in favor of it. But once again, for those women with peripartum who get bromocriptine as a way to stop lactation, they really only give it a 2B. So stopping breastfeeding is not supported in these guidelines. However, it is in some others. So any other recommendations postpartum? Well, the recommendation is once they're postpartum, get them on heart failure therapy as you would any others, considering safety for the baby if they're breastfeeding. So if they're breastfeeding, what can you give them? Again, now you can add on ACEs and ARBs. The ones we actually have some experience with are captopril and enalapril. So we tend to use those older ACE inhibitors. Spironolactone can be used. Now, still some of the newer agents we don't have safety data on, and so we don't use them. But now you have more of an armamentarium of treating the heart failure. That other issue of anticoagulation, I've touched on. Certainly if they have LV thrombus or they have AFib, they should be anticoagulated. The jury is not out if they should have prophylactic anticoagulation if they're not on bromocriptine. Remember, if you decide to use bromocriptine, which you may, you have to anticoagulate them at least prophylactically. So the ESC guidelines I've mentioned don't say anything about prophylactic anticoagulation. They just say therapeutic if you've got a LV thrombus or AFib. The ESC position statement, though, that I've been alluding to periodically, the heart failure ESC position statement with the diagrams of the severity of peripartum, they actually do suggest prophylactic anticoagulation because that high risk of LV thrombus. So again, we don't have a randomized trial and there's a difference of opinions in the guidelines. So my last few kind of concepts are how long does she need to stay on these heart failure medications? Indefinitely, 1 year, 3 years, till her EF recovers or none? So the answer is none. The current recommendation is that she should stay on them beyond the time her LV recovers. Let the LV recover, give her a year or two after full recovery, and then slowly start to wean. Now, how long should she stay? Should you wean off completely? There's some experts that say she should still be on something over the long term, maybe like a beta blocker to protect her ventricle. Others say once you wean off, you can wean off fully. There's no data to support one strategy or the other. But certainly you can start weaning at least some of the meds, and whether or not you leave one, say, cardioprotective medication on longer term, I think you have to decide on a case-by-case basis. Kind of the last concept in treatment is this issue of arrhythmias, because I've mentioned already that some women will die of sudden death. And so the question is, what do you do? We often don't put in defibrillators because some of these women will have full recovery. So it's a reversible cause, and we don't often put in defibrillators if there's a reversible cause of cardiomyopathy. But there is this idea of wearing these vests. So we haven't really used this a lot in Toronto, but certainly in the US, it's being used increasingly frequently. This is one study looking at 12 women who came in with peripartum cardiomyopathy, pretty bad, EF's less than 35%. 2 of them refused to wear this thing. You can imagine it's a hassle, especially with a newborn, especially if you're breastfeeding. They followed them, but shockingly in this one, there was 4 episodes of VFib with 3 successful shocks. No deaths, but pretty high rates of use of this vest. You would think it's perfect to use. However, then there's this other much bigger study of 107 women who came in with peripartum cardiomyopathy, sent home with a wearable vest. Nobody had shocks and there were no deaths. So I mean, these wearable vests aren't available everywhere. I don't think it's a simple decision. We don't have data one way or the other. I think you have to use clinical judgment of what to do about the arrhythmia risk. Certainly, if they're having ventricular arrhythmias, you're going to have to tackle it. But if they don't, I think individualizing is important. So those principles for after pregnancy, if they have heart failure, now you can ramp up your heart failure therapies, anticoagulate if they have LV thrombus, maybe consider if the EF's really bad. Think about what to do if you think there's a serious arrhythmia risk and consider contraception. So last questions of the day are, if she has full recovery, can she have another pregnancy? Yes, no, maybe. So she probably can, but my answer is maybe. I think it's whether or not she'll accept the risks associated with another pregnancy. And the risks are really based on whether or not she has full recovery of her EF or doesn't. So the red bars here represent women who had their index pregnancy with peripartum, got full recovery. The green bars represent women that came in with peripartum cardiomyopathy and never fully recovered. And the outcomes differ substantially. So let's look at the two outcomes. Heart failure, the first two bars on the left-hand side. The prevalence of the adverse event percent incidence is on the y-axis. So if you have another pregnancy, the chance of getting heart failure, if you walked into this one with full recovery after that index presentation, is 20%, still high. So you have to be able to live with a 20% risk, but perhaps not prohibitive. If you don't have full recovery, the chance is almost 45% that you're going to get heart failure again. So it becomes much higher. What's even more striking is this mortality group on the far right-hand side of the x-axis. If you have full recovery, the chance of dying in another pregnancy is 0. So you might get heart failure, you might end up with a bad EF that never recovers, but you probably won't die. But the mortality, if you come into the pregnancy with an LV that never recovered, it is almost 20%. So as a consequence, we advise women who have peripartum cardiomyopathy who never have full recovery to avoid pregnancy. We say pregnancies contraindicated. And if they have full recovery, I think you have to counsel them about those risks. So I'm going to summarize this talk, but I want to summarize it with those slides that I've gone through already from this excellent review by Melinda Davis. So remember, peripartum cardiomyopathy is a peripartum cardiomyopathy, a diagnosis of exclusion that presents at the end of pregnancy or mostly early postpartum. There's some risk factors like having hypertension or preeclampsia or being African American race that increase your chance of developing this condition. If you walk in the door with heart failure, remember you can give Lasix and do give Lasix. Don't worry about placental perfusion, treat the mom. You can use beta blockers, you can use hydralazine nitrates, but you cannot use ACEs and ARBs. If they're in really bad shape, think about a transfer if you need to transfer them to a center that has transplant and mechanical support availability. Once they're postpartum, things open up. You can now start adding ACEs and spironolactone. The ACE inhibitors, where we have the most experience again, are enalapril and captopril. If they have an LV thrombus, anticoagulate them. If they're having arrhythmias, you're going to have to figure out what to do about their arrhythmia risk. You have to individualize that and discuss contraception. I haven't talked to this a lot, but it's really important they have a reliable form of contraception, such as an IUD, so they don't get pregnant till their ventricle recovers, till they're better, until they can make an informed decision. And finally, really the after recovery, we don't exactly know how long they should take their meds, but most would agree a year or two after full recovery before you even start thinking about weaning medications, and weed them slowly and cautiously. And every time you take off a med, see how they're doing, check another echo, make sure they don't deteriorate, and use continued surveillance. So thank you very much for letting me be here. I'm going to open the floor for questions. I do want to mention, if you're interested in cardio obstetrics, we have a new JACC journal I happen to be the editor of called JACC Advances, and please take a look at it. We'll have some great reviews on cardio obstetrics, including in our first edition, which will be coming out next month. Thank you very much. And again, thank you for allowing me to be part of this fantastic session.
Thank you so much, Dr. Silversides. A very relevant topic. I have seen quite a few cases since being back home, but I see some questions from the obstetricians and the gynecologists, so I will start with those. Dr. Raymond Mansour asks, what is the risk of having another episode of postpartum cardiomyopathy in future pregnancy? You did broach it. And would we do anything different in that next pregnancy?
Yeah, so that's a great question. So again, the big issue of whether or not you're going to get into trouble is whether or not you recover from the first round. And so if you fully recover, you have about a 20% chance of getting heart failure, but you probably won't die. But if you don't have a recovery in the function of your heart, you'll have a 20% mortality. So if they don't have full recovery, they really shouldn't get pregnant. Now, what you would do, so many women do have full recovery. In fact, as I said, in North America, 70, 80% have full recovery. And many women will want to talk about whether or not they want another one and maybe have another one. The first thing is they need to be informed. They need to make an informed decision knowing what the risks are. Some women will hate the idea of having the chance of it happen again. Others will say, look, all I've ever wanted to have my second kid, let's do it. So then if that's the case, what I do is I follow them very closely. I make sure I do serial echocardiograms. I personally have them on a beta blocker because I don't know if it works, but it probably doesn't do any harm. And maybe it's helpful. I also would do serial BNPs, and certainly if there is any sign that something is brewing, I would follow them even more closely, maybe even weekly, and start Lasix if there was even a hint of heart failure, with this idea of trying to nip it in the bud if we catch it early. I don't think we really know how to stop the trajectory once it starts, but at least if you can prevent them from going into florid heart failure, you've prevented something.
Thank you. And Dr. Sherry Tulloch, also consultant in OBGYN, she's asking, she said, very informative presentation, Dr. Silversides, thank you. How do you distinguish heart failure due to severe preeclampsia in a chronic hypertensive from peripartum cardiomyopathy, since the biomarkers are similar and they have common risk factors?
Yeah, that's a great question. And that is something people struggle with a lot. I'll tell you how I kind of conceptualize it. First of all, when you have severe hypertension, you can go into heart failure. There's no doubt about that. One thing though, is you don't always blow out a ventricle. So some of it's diastolic heart failure or heart failure due to increased afterload. So they may still have an EF that's normal, but clinically they go into heart failure. So that becomes easy because if you recall, part of the definition is having an EF that's low. So if their EF is preserved still or even only mildly down and they're in heart failure with preeclampsia, it's probably preeclampsia related. Because it's not likely if you have a normal myocardium that you will have an EF of 20%, even if you have severe hypertension. Most of the time you can kind of rise to the challenge. So the way I differentiate is if the EF is significantly down, for me, it's peripartum cardiomyopathy. If it's not, it's preeclampsia with associated heart failure. But there is a huge overlap. We still don't know how to tease these two out. It's a very interesting overlap, and I think we're going to know more over the next decade. But right now, we struggle a bit with these two conditions because there is so much overlap. But that's a great question.
Thank you. Dr. Elliott is asking, is there any benefit of cardiac contractility modulation for treating postpartum cardiomyopathy?
Yeah, not that I know of. I mean, we really don't have good data. I mean, I think you use guideline directed care to whichever meds you can use that are safe. I showed you that Nigerian data showing beta blockers show some signal that you improve better on beta blockers, but otherwise there is no data about how to tackle that. And so I don't know if it might work. I mean, perhaps, but I would say on an individual basis, you might decide to try it if you thought the case seemed like it warranted, but there is no data.
And the beta blockers, are all of them options that we can use?
So that's another great question. So So there is one beta blocker we tend not to use in pregnancy, which is atenolol. So beta blockers are associated with lower birth weight babies. In general, it's not majorly lower birth weight babies, and so we use them for many things. But atenolol has been implicated in being associated with with that worse impact on fetal growth. And so we tend to avoid atenolol. For cardiomyopathies, we tend to use metoprolol, maybe bisoprolol, which incidentally there's less pregnancy data, but we would use it. But so personally, I use metoprolol all the time. And the only beta blocker I really wouldn't suggest is atenolol.
Thank you. Another question from Dr. Mansour. So population is about 98% Black, and we have about 1150 deliveries per year. What would be our expected incidence of peripartum cardiomyopathy? And this
okay. Go ahead.
All right. As this condition is a clinical condition diagnosed by exclusion, are there any screening tools we could use to guide us?
Yeah, it's hard. So screening tools, we don't use it here because our prevalence isn't high enough. I mean, maybe if, I would wonder, so Haiti I mentioned is 1 in 100, 1 in 200. Maybe screening tools would be useful. Somebody needs to develop those. They don't exist right now. But certainly if you're in a high prevalence location, a screening tool might be totally reasonable. That would probably be a way to go. Whether it's a clinical screening tool and or the use adding in an echo, I'm not sure, but somebody could certainly think of answering that question to see if it's clinically useful. But exactly what your prevalence is, I don't know. I tried to actually do a quick peek to see if I could present anything informative for you. But as I said, most of the data really is from Haiti, where it's like 1 in 100 or 1 in 200. But whether or not you're the same, I don't know, because without the data. So this is a perfect question for you to answer that might be clinically really meaningful if you could scoot through old charts and find some little sense of how often you see it. But even if you're seeing a few a year, then you have a prevalence that's probably, if the cardiologists are seeing a number of cases in a small island, you probably have a high prevalence, is my guess.
Thank you.
Great question, though. Every question here is great.
Thanks. So another congratulatory comment, and thank you for touching on treatment impact of neonatal outcome and breastfeeding. Another question, good presentation. Any role for the SGLT2 inhibitors?
Yeah, I wish we knew, but no safety data. So at least women don't have to pay $1 million for their meds because they're on old standard meds that are much cheaper. But yeah, we just don't know any safety data. Maybe in 5 years, maybe longer. I'm not sure. But
any more questions? So those are the questions we had in the chat.
Okay, well.
Thank you so much again for joining us. And we look forward to inviting you again another time.
Anytime. I'd love to return and learn from you as well.
Thank you.
Thanks.
At this point, we'll play some PSAs that we collaborated with INET, APUA, to create awareness in terms of heart disease and stroke.
Are you having chest pains, shortness of breath, nausea, vomiting, cold sweat or dizziness? Is your heart racing? You could be suffering from a heart attack. Don't wait. Seek emergency care immediately. It's crucial. Mind your heart.
This message has been brought to you by the Heart and Stroke Foundation and Antigua and Barbuda with the kind compliments of APUA INET.
Are you diabetic, hypertensive, or obese? Do you suffer from high cholesterol, or are you a regular smoker? Are you physically inactive, overstressed, or have a family history of heart disease? If your answer to any of these questions is yes, visit your physician to speak about reducing your risk of heart attack and stroke. Please mind your heart.
This message has been brought to you by the Heart and Stroke Foundation and Antigua and Barbuda with the kind compliments of APUA INET.
Did you know that having diabetes increases the risk of a heart attack by up to 3 times? Cardiovascular disease is preventable. Please speak to your doctor about what you can do to better manage your diabetes. And remember, mind your heart.
This message has been brought to you by the Heart and Stroke Foundation and Tiganda Barbuda with the kind compliments of AP.